Thank you. Thanks everyone for showing up. I have no disclosures, and when I was asked to give this talk, I thought about my father, Uri, and that's him over here on the left. This is my brother, my dad, and me. We went on a European trip, and my dad is Israeli, and so he has a hard time with the English language despite being here for about 40 years. And so English, according to him, there's real English and then there's my father's English. And so my father, one day at his birthday, said, well, I don't understand why you spell things the way you do in English. For example, the word book, you spell it B-O-O-K. You should spell it book, B-U-K. That's how he pronounces it. And he goes, and black, you spell it B-L-A-C-K. And he goes, no, you should spell it blick, B-L-E-K. And he goes, blood, you spell it B-L-O-O-D. You spell it B-L-A-D, blood. And so the way I kind of see this is my dad's English and real English is kind of bridging the gap between us surgeons and internal medicine people. And so this should really be called like Pleural Space and Pleural Disease Dictionary, and kind of bridging the gap between us, because there are many times that I get phone calls and the medicine resident, who's very nice and well-meaning, says, well, I think you need to do this. And I said, well, actually, that's that's not the procedure that we do. And so this is kind of to let you guys know what we do and to kind of help you with the lingo, so that way you don't feel like a tool when you call us, because you don't. You don't sound like one, but it's just to kind of help you understand what we do and why we do it. So the objectives are to describe the pathologic processes of the pleural space, to discuss the management of chest tubes, and to define the different surgical procedures involved with pleural space diseases. And so just to go over the anatomy, we've got two pleuras, the visceral pleura, which covers the lung, and it has no somatic intervention, and then you have the parietal pleura. And the space between each pleural membrane has a thickness of about 10 millimeters. And the parietal pleura covers the inner chest wall and the mediastinum. It's innervated by somatic, sympathetic, and parasympathetic fibers. And this goes around the entire chest wall. The transition is at the pulmonary hilum. And there's a potential space that exists between the visceral pleura and the parietal pleuras. And this is where problems happen. And fluid and air can enter that space. And in that space, that's where the pathologic processes occur, and that's why we put chest tubes in. And the way I describe these pleural processes to patients is, if you imagine your lung your chest is a trash can, your lung's a trash bag. Usually the trash bag and the trash can are together. The things that happen that we put chest tubes in are between the trash can and the trash bag. And this is just an important analogy to remember, because if you explain it that way to patients, they'll get it. The thing about chest tubes is they're not a benign procedure, and one intern told me any organ that can be injured by a chest tube has been injured. And so the organs that I've seen injured have been the left ventricle, subclavian artery, the diaphragm, the liver, the spleen, the pulmonary artery, the lung. So patients can die from putting chest tubes in. And so when he asked us to put chest tubes in, we have to think about, well, why are we putting them in? Is there a good reason? And the reason why we put them in is to get rid of something that is in the chest that shouldn't be. It's just putting it very simple. Or we want to prevent something from being in the chest that shouldn't be in there. So, for example, with a pneumothorax, you put in any ventilated patient, tension pneumothorax after initial needle relief, persistent and recurrent pneumothorax after aspiration, second large spontaneous pneumothorax, for malignant effusions, for empyemas, for traumatic hemothorax, and post-operatively, where we'll put them in after thoracotomy, after esophagectomy, and after cardiac surgery. And the reason why we put them in post-operatively is that is the window to our chest to let us know, is the patient having a complication post-operatively? So just to talk about pleural effusions, about 5 to 10 liters of pleural fluid moves across the pleural space every day. In the normal patient, there's 5 to 20 cc's in the pleural space at one time. And so we get into the Transudate and the Exudates, and there's a huge list. For Transudates, they can be CHF, cirrhosis, nephrotic syndrome, peritoneal dialysis, glomerulonephritis, mixed edema, sarcoid, pulmonary embolus. For Exudates, malignancy, infection, pulmonary embolization, any GI diseases, collagen vascular disease, drug-induced pleural disease, miscellaneous stuff such as asbestos exposure, sarcoidosis again, hemothorax, chylothorax, and this is where Light's criteria comes in. Labs for your pleural effusion. If you're going to send your effusion for anything, the two things you need to send it for at the very least are culture and cytology. that is the bare minimum. No one will blame you for sending them for both. I can tell you, I saw a patient in the ED a couple months ago, CHF, had a large left pleural effusion, did a thoracentesis on him, decided to send it off for culture and path like I always do. Everyone thought it was a CHF exacerbation, had a defibrillator, EF of 10%, came back as non-small cell lung cancer. So no one will ever blame you for doing that. But the other labs you can send it for are cell count, pH, albumin, glucose, LDH, protein, amylase, triglycerides, and that's if indicated, which is to rule out a chylothorax. So if you aspirate the fluid and it looks creamy, it could be a chylothorax. Another way to check, which is kind of a gross way, but if you actually let the fluid layer it out, and it layers out like a parfait, then it's fat and it's a chylothorax. So normal pleural fluid. The volume is usually 0.1 to 0.2 cc's per kilo. Protein can be 10 to 20 grams per kilo. Albumin is at 50 to 70%. Glucose is the same as plasma. LDH is usually less than 50% of plasma level. You can see the entire stuff in terms of monocytes, lymphocytes. The pH is 7.38. The bicarb is about 25 micromoles per liter. So we're going to talk about Light's criteria, which basically from a thoracic surgery standpoint, we have some dude named Light who was a pulmonologist who came up with this criteria, and we hate Light's criteria as thoracic surgeons because we have to memorize it for our boards because they're going to ask us about it and then we forget about it right after that. All that we care about is that the fluid needs to come out. And so it does, when I get called and they say, well, the LDH is this, you know, it looks like a transudate, I just know the fluid needs to come out and that's it. As surgeons, we're pretty stupid, okay? All that we care about is just cutting things and taking it out, okay? And that's what my brother always says, because you don't think much, you just go and cut and that's it. And I go, oh yeah, that's true. But for you guys, you need to know Light's criteria, and so you look at its ratios. So pleural protein to serum protein greater than 0.5, pleural LDH to serum LDH greater than 0.6. And the third one, which I feel is the same as the second one, is a pleural LDH greater than 2/3 of the upper limit of normal serum LDH. And that'll let you know if it's in that state. When you send the fluid analysis, you can look at the LDH. If it's greater than 1,000, it looks like it could be suggestive of an empyema, cancer, rheumatoid pleuritis, or pneumothorax. If your glucose is decreased, 30 to 50, you think of malignancy, TB, esophageal rupture, lupus pleuritis. Less than 30, rheumatoid pleuritis and empyema. pH is the same thing as glucose. Your cell count, if it's lymphocytes are greater than 85%, you have to think about lymphoma or TB, sarcoid, which I put twice, but chylothorax. Amylase can be increased in pancreatitis, cancer, esophageal rupture. And if your triglyceride is greater than 124, you think of chylothorax. So for chest tube placement, there's a safe triangle, which is at the level of the nipple, anterior axillary line. This is the safe area. But when you put a chest tube in, you want to make sure that you're actually in the right spot, because things can move, okay? Your heart can be shifted over to the left, your diaphragm can be elevated. So ways to make sure that you're putting your chest tube in the right spot can be an ultrasound to see if there's fluid there, or before you even make your incision, sticking a needle in the chest and aspirating. And if you get what you're looking for, then you know that's the spot to make your incision. When we put our chest tube in, we anesthetize the area. You can stick your needle in the pleural space, as you can see here. There are two ways. You can use a Seldinger technique or a more traditional technique, which is using a Kelly and kind of going through and spreading through the tissue, and then you pop in. Usually you should get a big rush of air, fluid should spill out, and then you put your chest tube and you suture it in place. But the thing that you guys aren't really going to put chest tubes in, but it's managing it, that unfortunately when we get consulted on your patients and we put chest tubes in and something bad happens, you're the guys who are called in the middle of the night, not us. And so just to kind of go over what a Pleurovac is, it basically has multiple chambers. So you have a collection chamber, which collects the fluid. And so you want to, when it tips over, it has all these different lines, and then you can't tell how much is coming out. So you always want to make sure that it hasn't tipped over. It has. Have them change the Pleurovac. You have a suction control here, and that way you can make the suction either higher or lower. So it's not the suction on the wall that determines how high it is, it's this dial. And then you have the water seal. When you have your Pleurovac in suction, there's a little orange doohickey here that springs up. So you can have it hooked up. The nurse, a well-meaning nurse, can think that everything's hooked up, but the suction's not on, or there's not enough suction. So if you don't see this little orange doodad up there, you're not on suction. To check for an air leak, when you have them cough in your water seal chamber, you'll see bubbles. Sometimes you can have patients cough, and you'll see the bubbles go through. If the patients are tidling, which means they take such good breaths, you actually see the air level move up and down, and it can shake. And so things that you can do to determine, is it a shake or is it actually an air leak, can be you can have them hum or you can have them bear down like they're having a bowel movement. With intubated patients, you clamp the tube for several breaths, let the air build up, and then you unclamp it. And then if you see bubbles, that's how you determine if there's an air leak. There are multiple connection sites for a chest tube, and so patients can actually have an air leak with the tube actually disconnected. So I've seen where the chest tube actually connects to the tubing of the Pleurovac, completely unconnected, and the nurse says, oh, the patient has an air leak, and the reason why is because it's suctioning air from the environment. I had another patient actually on my floor who they said has a rip-roaring air leak, and surprise, surprise, the chest tube was not sutured in place and was laying down next to her. So when you... And this happens, okay? This happened on the cardiothoracic surgical service, so it happens to all of us. But you want to look at all of your connections to see, are they hooked up okay? The other thing to realize is that your chest tubes have what we call the sentinel hole, or the last hole is actually radiolucent. And so if that hole is not in the chest, you can have an air leak, and your chest tube's not doing what it's supposed to be doing. So look at your x-rays, see where that last hole is. So when do we remove chest tubes? Well, when it's finished doing its job. So usually when there's no air leak or the output's less than 200 cc's in 24 hours. So I know a bunch of you have had patients who we keep writing, please keep an eye on the chest tube output because we're not going to remove the chest tube when it's less than 200 cc's. And so it's important to encourage nursing and for you guys to keep an eye on the output, because if we don't know what the output is, that thing is not coming out. The other thing is that there are special considerations where we will leave the chest tube in. So there's something called an Empyema tube, which is when patients have an empyema, which we'll go over, we actually leave the tube in and let it form a fistulous tract so that way the pus can drain out. Or when patients are on high PEEP. There's no point in taking a chest tube out in someone who's on 12 of PEEP, okay? That's not what's keeping them in the hospital. If we take out the chest tube and then they all of a sudden develop a pneumothorax and we have to rush over there, put another chest tube and it becomes an emergency. So we kind of need to think, well, is it safe to remove the chest tube in those patients? So pneumothorax. So there's classification. You have different types. Spontaneous, you have the primary one. Chronic, which can be in secondary, so if patients have COPD, neoplasms, so lung cancers can perforate and create pneumothoraces. Catamenial. Do any of you guys know what a catamenial pneumothorax is? Raise your hand if you do. Don't be shy. So that is a lovely pneumothorax that occurs to women who have endometriosis. And so every time they get their period, they develop a pneumothorax. And people are unsure if it's because of endometrial implants on the lung or if it's because of fenestrations in the diaphragm and they have endometriosis in their abdomen. So then when they release gas in their abdomen, it causes a pneumothorax. I actually have a patient who has recurrent catamenial pneumothorax, and every month I get a call from her, so I'm privy to her menstrual cycle, and she lets me know when she has one. Post-traumatic, so you can have blunt or penetrating. Iatrogenic, so it can be from doing a thoracentesis, from putting a central line in. What happens is you have increased airflow into the pleural space until there's no pressure difference. And so then you have this pressure gradient between the apex and lung base. And then you have decreased lung compliance, decreased functional residual capacity, decreased ventilation, and you can have decreased oxygenation and a slight shunt on these patients. So when patients have a ruptured bleb, they can present in different ways. One can be with pneumomediastinum. I had a patient who was doing, I think it was his frat party, no, it was his hazing for his fraternity, made him do 1,000 sit-ups and push-ups, and then vomited and presented with pneumomediastinum, and it was a ruptured bleb because he valsalvated so much. You can have pneumothorax, or you can have subcutaneous emphysema without a pneumothorax. So I want you guys to raise your hands. Who thinks the patient with pneumomediastinum needs a chest tube? Raise your hand. Okay, pneumothorax. Raise your hand. Subcutaneous emphysema without a pneumothorax. You guys are all right. So it's a pneumothorax. Subcutaneous emphysema will not kill the patient. Okay, it can be scary. They can develop it in their eyes, and their eyes shut down. You can have vocal changes in these patients, so their voice becomes a lot more nasal because the air will actually track up to the vocal cords. Keep an eye on the urine output in males because, believe it or not, subcutaneous emphysema can actually track down to the scrotum and can engulf the penis, so that way men are unable to urinate. So it can go everywhere. So I'm going to give you some clinical scenarios. So you have a 55-year-old male, history of COPD, admitted to the ICU for pancreatitis. He has acute onset of shortness of breath. His blood pressure is plummeted. O2 sats are 85% a non-rebreather. He has absent breath sounds on the right. What do you do? And just shout it out. Right, okay. So this is a tension pneumothorax. So the cause of death in these patients is actually you're decreasing your cardiac return because it's kinking off the vena cava. So this is a clinical diagnosis, not a radiographic diagnosis. So you have continuous airflow, increased intrapleural pressure, you have mediastinal shift, decreased ventilation, increased shunt, decreased oxygenation, increased cardiac stroke volume, increased heart rate, but these patients are going to die if you don't do anything. And the way you do it is you actually stick a needle, usually 14-gauge Angie catheter, mid-clavicular line, just stick it in there, aspirate. You feel like a total badass when you put it in because it's like Pulp Fiction. When you go in there, you jab it in, all of a sudden you're psh, and the patient does well. So what do you do after that? You have to put a chest tube in. So indications for operative intervention for patients who have pneumothoraces. So with your first episode, if you have early complications or prolonged air leak, if you have non-re-expansion of the lung, if it happens bilaterally, hemothorax, a tension pneumothorax, a complete pneumothorax, which is the same as tension, but potential hazards if they have an occupational hazard, so fighter pilots, scuba divers, absence of medical facilities in isolated areas, associated single large blowers, psychological, so if they're not going to be able to recognize whether or not they have a pneumothorax again. If it's a second episode, so the risk of recurrence after your first pneumothorax is 20%, after your second is 40%, and after your third one is greater than 50% that you're guaranteed to have a pneumo. So our intervention is called a pleurodesis. What a pleurodesis is in order to create a Velcro-like reaction between the lung and the chest wall. These patients can develop pneumothoraces again, so they can have ruptured blebs, but because they have those adhesions, the lung's not going to collapse. So you can have two types of pleurodeses. One is chemical, which is usually reserved for malignant effusions, but we can use it for pneumothoraces. And this is permanent, so once you put chemicals in there, it is so hard to get in, it's near impossible. And we can use talc, bleomycin, or doxycycline. Another way is to do what we call an apical pleurectomy, mechanical pleurodesis, and bleb resection. So it is, we go in there, we wedge out whatever blebs we can see, usually in the apex and in the superior segment of the lower lobe. We take out the pleura apically, and then we actually take a Bovie scratch pad, so imagine taking a Brillo pad, and you rough up the inside of the chest wall, okay? And the way we know when to stop is when it looks like vomited beefaroni, so it just looks gross. But the end result of it is inflammation, okay? And so that way you form that apposition. And so because of that, we try to avoid NSAIDs, Toradol, prednisone, because we want the inflammatory response. So this is a 72-year-old female who I saw in consultation, history of breast cancer in 2004, status post a right modified radical mastectomy, had progressive shortness of breath in the past month. She had a chest x-ray that showed a large right pleural effusion, underwent a thoracentesis yielding 3 liters of serous fluid. And this was her chest x-ray. So if you look at it, the lung is over here, and you're tracing it, and you see it over there. So it's read as a pneumothorax. So this is our CAT scan a day later, and you can see air and fluid in there. This is actually what we call a trapped lung, or fibrothorax. So it looks like a pneumothorax, and technically it is, but the pathology with it is that the lung has formed scar tissue around it, so it can't expand. And so scenarios with trapped lungs can be benign. For those patients, we do decortication, which I'll go into later. But what happens is, whatever the etiology is, the lung forms a protective shell. Imagine like an orange peel, okay? And it's not going to expand no matter what you do. There's something mechanically keeping the lung from taking up the space. So it can be a hemothorax can cause that, empyema, peripneumonic effusions, malignant effusions, which in those cases we put a Pleurx Catheter. And if they're too sick for a decortication, we do something called an Eloesser flap. And I'm going to go into each one of those to explain them to you. So Pleurx Catheter is basically an indwelling catheter that has a Dacron cuff, and these patients go home with them. And basically what they do is kind of like doing daily thoracentesis. They have this bulb, they drain it every day, and then slowly we wean them off of it, and we take them out at home. This can be a potential entry from the environment into the chest. So they can develop empyemas from having Pleurx catheters in, which can be very difficult to control and can be deadly. But it's something to bear in mind. So whenever I see a patient with a malignant effusion, we talk about tau pleurodesis, which is my first bias. However, if they don't want that, or if their lung's trapped, then we'll put a Pleurx catheter in, but they have to understand that there is the risk of developing an infection from that. An empyema is basically a zit of the chest, okay? And pathologic findings. So there are 3 phases: the exudative, or the acute phase, the fibrinopurulent phase, or transitional phase, and stage 3, which is the organizing or chronic phase. And this disease progression is over 3 to 6 weeks. And so the exudative phase, you have the pleural membranes and discharge, then forms this exudative fluid. You can have a peel or a rind that occurs all around the lung, but it's not thickened enough to prevent lung re-expansion. Stage 2, you start having heavy fibrin deposits all over the pleural surface, parietal more than visceral. The pleural fluid can be turbid or frankly purulent, and you have increased polymorphonuclei. The pleural is still relatively intact. The lung can be re-expanded. You can have loculations in this stage. In about 2 to 4 weeks, you can develop your organizing phase or your chronic phase. So you have fibroblasts form, you have a fibrothorax, and you develop a thick fibrous peel. And it's at this point that putting a chest tube in is not going to help. And it's usually stage 2.5 to 3 that they need operative intervention. What a decortication is, the goal is to have the lung re-expand. And this is not a benign procedure. This is a very difficult procedure because the peel has formed in the lung. It's nice and adherent. And so what we actually need to do is take a scalpel, incise it onto the peel, try to find the right plane. So if any of you guys ever had sunburn and you like to pick your skin off, if you go too deep it hurts. Well, if we go too deep with doing our decortication, we're in the lung. And so we have to find the exact plane, tease it off, and work over the entire lung. And this can take over 6 hours to do because the goal is to get the lung re-expanded. If the lung is not going to be re-expanded, you're not going to do the patient any good. And so I'm going to present some cases of some patients that I've had with this. This is a 63-year-old male, no significant past medical history because he hadn't seen a physician in about 20 years. I'm sure you guys have seen those patients as well. He presented with shortness of breath, weight loss, fevers, and chills. Went to urgent care, treated him about 4 courses of antibiotics, no relief. Has a white count of 39. And so he was seen in the ED, and this is his CAT scan. When you look at a CAT scan for any effusion, yeah, you want to look at your lung windows, but also look at your mediastinal windows, because that's actually going to when you look at this, you see this big white blob here. But with your mediastinal windows, here's this big area of fluid with some air, and you see the lung over there. So it shows you what's fluid and what's lung. Going further down his CAT scan, you see this lovely air fluid level with atelectatic lung. So we ended up doing a bronchoscopy, right thoracotomy with decortication. The reason why I did a bronchoscopy was to see, is there an endobronchial lesion in this patient? Because what can happen is when patients have lung cancers with an obstructing lung cancer, they can actually present this way. And you can do the best decortication, but the lung's not going to expand because air's not going to get to that lung. We did a right thoracotomy with decortication. We found 3 liters of pus in his chest and a thick peel involving the entire right lung. His EBL was 500 cc's. The reason why I knew that I could not do this thoracoscopically was because of this rind that was formed in the air fluid level. So I did not putz around with a thoracoscopy. I did not put a chest tube in. I knew this had been going on for at least 4 weeks, and this required an extensive procedure. This is a lady who I operated on the day before yesterday until 8 o'clock at night, so it was a 6-hour procedure. 63-year-old female presented to an outside hospital about 3 weeks ago with strep viridans. They did chest tubes in her, they did multiple thoracentesis. They did a week of antibiotics, and then they transferred her over to me. And what you can see here is this enhancing area, this rim, over here and over here. That's the rind, okay, that's around the lung. So knowing that I was going to give this talk, We took pictures of the rind for you guys so you can see what exactly it looks like. And actually, the rind was so thick and adherent in the lower lobe that I couldn't take it off the lower lobe. So what we actually do is we get creative when we take the scalpel and we do tic-tac-toe marks on the lung. So that way it'll actually be able to expand. And she is still on the ventilator right now. It's her second post-operative day. So it's just a huge procedure. Contraindications, decortication, extensive disease in the collapsed lung, bronchial stenosis. You have relatively absolute contraindications, which would be uncontrolled invasive infection, significant operative risk. So one of my first consultations here was a Jehovah's Witness who had a hemoglobin of 6, who needed decortication. Debilitated contralateral disease. Relative decortication, if they have minimal symptoms, and this is from something remote, and they're not sick, and there's no white count, there really isn't a need to go in there. Dr. Moran always says, you can't cure asymptomatic. So the other thing is that they have little evidence of physiological impairment. So for those patients who have absolute or relatively absolute contraindications, we'll do what's called an Eloesser flap, which I know freaks you guys out when you've seen them. It's basically a big hole in the chest. So we cut out a few ribs. We actually involute the skin onto itself. And so you have a big hole going into the chest. And you do wet to dry dressings, let it granulate from the inside out. And so it's basically like lancing an abscess. Remember how we discussed the empyema looking like a zit? This is the major zit drainage for these patients. So I'm going to ask you a few things to see. Let's see if it'll go. So, true or false? An Eloesser flap is permanent. How many say true? Okay, how many say false? How many abstain because you're too scared to raise your hand? False. Once the wound is clean, muscle flaps can actually be used to close the space. And with the post-pneumonectomy, bronchopleural fistula, so there's nothing in there to fill up that space. You can actually see the heart in there. You can actually put muscle, we can put antibiotic solution, you can close it up on those patients. So, let's see. You can sometimes hear the patient's voice and breathing in the Eloesser flap cavity. How many trues? Falses? You're right, that's normal, okay? If they have a bronchopleural fistula, which means a hole in the bronchus, you can actually see air coming out of it. So it's okay, it doesn't hurt anyone. Last one. The patient can get a tension pneumothorax with an Eloesser flap. Trues? Falses? Yes, okay? So the space is open. Air can come out of there. And when we do an Eloesser flap, that is definitive procedure for the infection. So there are many patients who've had it that we've gotten called and say, oh my God, he has an empyema. Yeah, we know that. That's why we did the Eloesser flap. So it'll heal. It's okay. Don't worry about it. So, let's see if this will go. Conclusions. Pleural processes can include effusions and pneumothoraces, and a chest tube is not without its risk. And care must be taken to understand when to place a chest tube and when to remove a chest tube. A pleurodesis is done to create pleural symphysis for effusions and for pneumothoraces, but a decortication is performed to help with lung re-expansion from the fibrothorax, okay, from these chronic processes. The thing to realize is when in doubt, just page us. We're available all the time, okay? And we don't mind you guys paging us and saying, we don't want to consult you, can you look at this CAT scan and let us know what you think? That's fine. We're more than happy to do that, but what we would hate is to have the patient be on your service for 4 weeks, and then you're asking us to be involved, and then we have a patient chronically on the vent, because there are things that we can do early that don't require Eloesser flaps, don't require thoracotomies, etc. And now I'm just going to do a shameless plug that we have the Eastern North Carolina Lung Cancer Symposium a week from today. It is a symposium basically aimed toward you guys, primary care providers, about the management of spots in the lungs, what do you do, how do you treat lung cancer, and kind of an intro to kind of bridge the gap. So it's next week. It starts at 9 o'clock. It's at ECHI to ECU. We're giving out CMEs, and we'd appreciate if you guys could come and support us. And that's all I got for you. Thank you.